Hello, everybody. Welcome to the tutoring session. Nice to see you all here. Just out of curiosity, how many of you guys have already taken the exam that's due on Thursday? Not Ethel, not Carla. Bailey, Melissa?
No, I have not.
Okay, thank you. Thank you. Okay, so what I was planning on going over stuff for musculoskeletal, but I think we'll have plenty of time during our flipped classrooms this week to go over questions that you have for that. So would it be helpful to go over stuff related to EKGs, strokes, hypertension, things like that? Would you like to go over that?
Yes, please.
Okay, awesome. Good. Okay. So anybody have any specific questions you want to start with? Because we've already kind of done a bit on the outlines in the past two tutoring sessions, but does anybody have any specific questions regarding anything in that realm?
I have a question about the atrial flutter.
Okay.
Because there's two types, right? One that's stable and unstable. So if we were asked a question, would we know, how would we know whether it was unstable or stable? Would you tell us?
Very good question. I could tell you, or to know if they're stable or unstable, look at their vitals. So someone who's unstable is going to have hypotension or decreased level of consciousness or decreased urine output. All three, one, two, or all three of them. But that's how you decide if someone's unstable. And that's a really big.
Can you repeat that?
Absolutely. So decreased level of consciousness, decreased urine output, hypotension. Decreased urine output, decreased level of consciousness, and hypotension.
And that would be unstable.
That would be unstable if they had any or all of those three.
Okay.
Mm-hmm. That's a very good question, because a flutter isn't the only one where you have to differentiate, because anytime a patient is unstable with anything, the answer's got to be electricity. Because with AFib, remember, AFib, you only do it if they're unstable or if they're stable and it's been less than 48 hours, or if they're on Coumadin for 6 weeks, right? So you got to be able to differentiate with AFib too. So yeah, that was a really good question, Carla.
Thank you.
You're very welcome. Anybody else have any specific questions?
I watched the other reviews and it did help tremendously to narrow it down, but I still feel like there's such a wide array of information, and I don't know. I know you've narrowed it down, but I'm just hoping we can narrow it down again. I am really struggling. I never wait this long to take exams, and I do not even feel close to ready. So, and I don't know if anybody else feels like that, but I am just struggling big time.
I gotcha. Okay. So let me talk a little bit, see if this helps. And if this doesn't really answer your question, maybe Melissa, you can craft a more specific question, but I'll try and answer kind of maybe what you're thinking. So half of this test is EKGs. Okay. What I will be doing is giving you a strip and asking you what to do, right? You've got to be able to know what that strip is almost all the time to know what to do. When I say almost all the time, because second degree type 2 and third degree are the same treatment, right? So if you can't make sense, is that a second degree type 2 or a third degree? Doesn't matter. We treat it the same way. So you don't need to worry about that one, okay? The other half is going to be on stuff we talked about last week. Hypertension, strokes, aneurysms, peripheral vascular diseases, okay? Remember, peripheral vascular disease has PAD, which is the arterial diseases that have Berger's and Raynaud's. And then we have venous diseases that all start with V, VTE, varicose veins, venous insufficiency. And remember that all three of those kind of cause each other. They're all very closely related. You rarely just get one without the other two, right? Let's see, hypertension. We want to make sure that we know over 140 systolic is hypertensive. Over 180 systolic is hypertensive crisis. The crisis has two parts as well. Crisis has urgency and emergency. Emergency is the one with organ failure. evidence of organ failure. And evidence of organ failure is going to be messed up vision, usually it's like double vision or blurry vision, and or decreased urine output. Okay. Let's see. And then strokes, we talked about 2 different types of strokes, ischemic and hemorrhagic. Ischemic is the one with the clot. You've got to treat it with TPA within 6 hours of symptom onset. If it's after 6 hours of symptom onset, it's not worth the risk because TPA has a lot of risks. Hemorrhagic stroke is when there's bleeding in the brain and we either wait and see or they need brain surgery immediately. Okay. Does that help, Melissa? I'm not sure if that helped kind of narrow it down, but those are kind of the biggest concepts.
Yeah, I focus so much on the ECGs and everything that I'm like, oh yeah, there is the other half of the exam, but I do feel like it is a review from last semester, so hopefully I'll be okay that I haven't focused so much on that. I do feel like I can look at each ECG strip and tell you what it is and tell you what the treatment is. So maybe I need to quit stressing.
Yeah, if you could do that, that's over half of the test. And you're right, the stuff that we covered last week should mainly have been a review. Really, the only new thing I've taught you guys is EKGs. Everything else should be a review where we kind of incorporate patho and pharm and nursing into one big class, which is why my class is so freaking long. Okay, any other questions?
Okay, I do have one more. Sorry.
Yeah, no, don't be sorry. I like the questions.
So adenosine is the only time we use adenosine is for it's VTAC? SVT, sorry, supraventricular. Okay, it's SVT. So that's the only time you use adenosine. And then Correct. I'm trying to remember the atropine. I like how you said attaboy, like we're coaching it along, like let's go faster. So for the amiodarone, that's more of a, like we're going to stabilize their rate. So you could say that that's kind of the heart's maybe beating too fast. And that's why we do that one.
It's to stabilize the rhythm. So think of it as the rhythm because we can use it for AFib that is going slow and AFib that's going fast. So I don't want you to think of it as stabilizing rate. I want you to think of it as stabilizing rhythm.
Mm-hmm. Not a speed. Okay. So rhythm, not rate. Okay.
Rhythm, not rate. Yeah. Very good. Okay. Anybody else have something?
I do.
Go for it,
for like the different side brain injuries, there's one that can affect both, and it's the hemianopsia.
Hemianopsia.
I have a question with that one. Is it that they can't, so if there's damage here, it's affecting the right side. So does it mean that like they still have vision, but like they can't see this, but they can kind of see this? Does that make sense what I'm saying?
There's 2 ways hemianopsia can go. If you have a stroke here, it can completely black out this eye, or it blacks out this side of both eyes. So there's 2 ways it can go. Either do this or this. And then if you have it here, it can either do this or this. So it blocks out half of the vision on both eyes.
Wait, so it wouldn't like affect, so it doesn't affect like the outer eye vision? Nope. It's like the right side of the eyeball?
This stroke can affect the left side of both eyeballs or the entire left eyeball. Yeah. And I don't know if you realize this or not, but hemianopsia can happen both sides. So can hemiparesis and hemiplegia. It just happens on opposite sides.
And those ones, because when I was reading online, I was trying to look at pictures, you know, because sometimes they have pictures and it helps you remember things. But it made it seem like those words were used interchangeably. But then I thought that one had to do with weakness and one had to do with paralysis.
Right. So hemiplegia, like paraplegic is how I remember it. That's the paralysis one. So if I have a stroke here, if it's a really bad stroke, my left arm, left leg, left side of my trachea, left side of my diaphragm, the left side of my entire body can be completely paralyzed.
Okay.
If I have hemiparesis, that just means the left side is weakened. It's not as strong as the right side. But you're right. Lots of people do use those interchangeably, but technically, like ischemia and infarction, They're not
Okay.
technically the same thing.
Okay.
So yeah. The biggest things to remember that you need to know about hemiplegia and hemianopsia are unilateral neglect and how to take care of that, and hemiparesis, or sorry, hemianopsia and how to take care of that. So remember, hemianopsia, we were clarifying with Carla, is half your vision. So if they are missing vision out of this eye, because they had a stroke here, so they're missing, well, they had a stroke back here, but on this side, they're missing vision here. I'm going to be nice and put all their stuff over here so they can see it. But if I have unilateral neglect, let's say I had a stroke here and I'm just ignoring, I'm going to put their clock and their food and everything over here because I want them to look and see the side of the body they're ignoring and use the side of the body they're ignoring. So with hemianopsia, like I said, you get to be the nice aunt. Oh, you want your cookies over here? You want your clock over here? Let me stand over here so you can see me. But with unilateral neglect, you're the mean mom. Look over here. Your stuff is over here. No, use this hand. You've got to teach them to get over unilateral neglect. You can't teach them to get over blindness. Right? So that's kind of the biggest concept that I see students mix up there is hemianopsia and unilateral neglect. Anybody else have any questions? Okay, what do you want me to go over then? Because we've already kind of gone over, right? You've already had 2 tutoring sessions, and I feel like we'll talk about musculoskeletal stuff this week. Carla.
I have another question.
Okay.
The EKG strips with like the small boxes, the large boxes, like the less than 0.2 and that stuff. I don't know that I understand that.
Okay.
Or I don't know how much I'm supposed to understand about that.
I gotcha. What I need to go.
Will there be questions that say like how long is the QT interval? Oh, yes. Great. Okay.
Yes. So let me get up my little whiteboard and let's do something quick here. Okay, let me share whiteboard here. Okay, can you see the whiteboard, guys? Yeah.
Yes.
Okay. So let's say this is one big box on an EKG strip. And you know it's big because these lines are going to be real nice and thick. Okay, nice and thick here. This box demonstrates 0.2 seconds of time. So to get a whole second of heartbeats, you'd have to do 5 of these boxes, right? Because 0.2 times 5 is 1 second, okay? But each of these big boxes are further divided into 5 smaller boxes, like this. Okay. And each of these smaller boxes, just from here to here, is going to be 0.04 seconds. Okay. So let's do, I want you to tell me how big this PR interval is, okay? So here we go.
Sorry to interrupt you, Professor.
Yeah, go ahead.
Sollis. So this 0.2 second comes from that bigger box.
Yes. So let me.
And this isn't the bigger box, right?
This is the big box right here. So this big box is 0.2 seconds. And this little teeny box right here is worth 0.04 seconds.
Okay.
Really, you only have to memorize this or this. Because if you memorize 0.04 and then you add them up, 1, 2, 3, 4, 5, and you do 0.04 times 5, you get 0.2 seconds. So if you want, you can just memorize that depending on how good your multiplication and division skills are. Okay. Okay. So I want you to find the PR interval for this EKG that I'm going to draw. Okay. So let's say it starts here. Just to be nice, we're going to start on one solid big line and we'll do this. Okay. So take a look there. See if you can figure out what the PR interval length is. Do it in your head and then we'll do it together. Okay, we ready? So the first thing you have to do is know what the PR interval is, right? The PR interval is going to go from the beginning of the P wave to where it either dips down or dips up. It doesn't go all the way to R. Even though it's called a PR interval, it doesn't go all the way to the R. It goes to here. Okay, so now we got to figure out how much time did it take to go from this big red line to this big red line. Well, I've got one box, that's 0.04 seconds. I've got two boxes, that's 0.04 seconds. I've got three boxes, that's 0.04 seconds. And then I've got a little teeny bit extra. It's so small that I'm just going to round. So I do 0.04 plus 0.04 plus 0.04, which is 0.04 times 3, right? Because we just did it 3 times. So that would give me 0.12. That would be a PR interval of 0.12. And if you get anywhere within this realm, if you can do positive or minus 0.04, and I'll still give you credit. So instead of 0.12, if you got 0.08, you would still get it right. And if you got 0.16, you would still get it right. Anywhere within that number, I would give it to you. You would get the credit.
So why do you not go to the dip, like all the way down to the point?
Because
You
PR
only go to the
intervals,
start of the R.
right? Because PR intervals sometimes go like this, and they don't have a dip at all. Sometimes they're like that, and that's okay. Some people just doesn't dip like that, and so we didn't want to make it go all the way to a Q. So the PR interval technically just goes from the beginning of the P wave till it changes off of that isometric line, till it goes up or down. So that's just kind of the definition of a PR interval, is to go from that area to that area. Carla, did that help? Melissa, did that help?
That helped a
Oh,
ton.
good. Okay.
Yeah, I remember I did the 0.12, but then I also did the 16 because I was like, I can't remember, but I'm pretty sure it cuts off like at the Q.
Yeah. So if we wanted to, we could take this further and say, this is my PR interval, and then this is my QRS here. And we could do 1, 2, 3.5 if we wanted to. And we could do 0.04 times 3.5, which will give me 0.14. But see, that will still get me within that range.
So would you give us like a range as options, or would, oh, okay.
No, it would be a fill in the blank. And the fill in the blank is programmed to do a range. If they answered anything between 0.08 and 0.16, they get the answer right.
Oh, okay.
Yeah.
Okay.
So yes, there are questions on the exam where you have to measure intervals. Now, why do you think measuring the PR interval is so helpful anyway? Why do you think we keep asking you to do it? Any ideas? So the point of the PR interval is so you can assess for heart blocks, right? Because the first question Dr. K taught you to ask was, is there a P wave and is there a QRS after each P wave, right?
Right, because the heart blocks have to do with the PR length.
Exactly.
Oh, okay.
So a first degree heart block has a PR interval that's 0.2 or longer. So it took a full big box to go P and then to the QRS complex. It took more than a full big box. So that would identify a first degree heart block. And when you ask yourself, well, is it P? Is there a QRS? Okay, there is a P, there is a QRS. It's going at a good rate. The only way to differentiate between normal sinus rhythm and first degree heart block is to measure that PR interval. Is that PR interval 0.2 or more, then it would be a first degree heart block. If it's less than 0.2, it would be normal sinus rhythm. Now, when you get into second degree type 1, your PR interval is longer drop, then you have a second degree type 1 block, right? Even though the poem says winky block, we don't use winky block anymore. So longer drop. So your PR interval is normal. It gets a little longer, and then you have a P wave with no QRS. That's your drop, okay? With second degree type 2, your PR interval is fine. It's fine every time you have a QRS, and then suddenly, randomly, there's no QRS complex after. So the PR interval is normal until it's completely missing. Okay, that would be a second degree type 2. And then a third degree heart block, if you could even figure out a PR interval, which you really can't because there's not enough QRSs, each PR interval would be a completely different length than the last one. So the PR interval for third degree would be completely variable. It would be changing every time.
So for the first degree, if it's less than 2, no, greater than 2, then it's a first degree, right?
Greater than 0.2, yes.
0.2. So why is there not a treatment for it? Is it because there's still a PQRST?
Yeah, they're still getting good rhythm, good output.
Okay.
In fact, we caused it, right? The number one cause of a first degree heart block is going to be like beta blockers. We gave them cardiac meds and it caused them to have a first degree heart block. It is so innocuous, so gentle. It doesn't even matter if you have a first degree heart block. Okay, we leave them on those meds. What we start getting concerned about is if it's second degree type 1, we're going to change the meds. And if it's second degree type 2 or third degree, their AV node's pretty shot. So we would fix those two. Do you guys feel better about heart blocks and measuring?
I do feel better about the measuring.
Good.
Yeah.
Okay. What else would you like to talk about? Anybody? I just want to focus on wherever you feel you need the information. Because like Melissa said, you guys have already heard about strokes and stuff like that. So just let me know where you want me to talk and I will.
My mom actually this weekend, she had to go to the ER because she
Your
was
whole
feeling.
family lives at the hospital, woman. Okay, why did she have to
They
go to the
do.
ER?
Because they were getting ready to go back to California and she felt super nauseous and dizzy. And I took her blood pressure and it was a little high, but not super bad, you know? So I was like, Mom, do you feel bad going home? And she was like, no, not really. And I was like, okay. She was like, I just feel really dizzy and nauseous. So I'm just gonna sit in the car and just put a like wet towel and I think I'll be fine. They didn't even make it to the freeway. She was like, you know what? No, this isn't gonna work. Like we're gonna have to stop so many times. No, I don't. And so I took her to the ER and they did like a CT scan to make sure she wasn't having a stroke. And she was fine. She just had vertigo. She's never had it before. So
It's
they gave her
unpleasant.
some medicine for it. It is. She looked
It's especially unpleasant if you're not driving and you've got car sickness on top of vertigo. Yeah. She wouldn't have
And
made it.
she likes to go to the hospital if she needs to, but she also likes to get out fast, you know, like,
Right,
okay,
right.
cool, I'm fine, let's go. But they gave her diazepam and then she was kind of like falling asleep.
Completely
And
loopy, yeah.
right. And the doctor was like, excuse me, ma'am. And she was like snoring. She was like, I think she's out for a while. So let's just let her rest, come back later.
There you
I was
go.
like, okay.
Good,
So,
good. Well, that's
yeah.
kind of one of the better things it could be, right?
Mhm. Yeah.
So stroke, how high was your mom's blood pressure when you took it? Do you
Oh
remember?
my gosh. Yeah. Her blood pressure was like 140 over 70,
Okay,
75,
so
something like that.
that's definitely a hypertensive event, right?
Yeah.
But if she's used to being like systolic of 100, 140 could easily cause a stroke, right? If she's used to being super low and she goes up by 40 points, that's a lot. So I could totally see how that could cause
Her
issues.
average, I think, is like 130.
Okay,
you
so
know?
then going up
So
10 points isn't a huge deal.
Right. So I was
Right.
like, I don't think it's that bad. But then when she got to the hospital, she was like 209 over
Yowza.
90 something.
Well, of
And I was
course
like,
they look
well, that's a
for
high
a
blood
stroke,
pressure.
right? Yeah.
Yeah. And I texted Brianna and she was like, did we mess up on that blood pressure reading? I was like, no, we didn't.
Chances are she just kept going up because of the stress of being
Right.
feeling sick, of delaying the
Mhm.
family from getting home, things like that.
Yeah, and she has these dumb dogs that she cares for. So she was like, who's gonna take care of my dogs?
Oh, of course that causes more stress, for sure. For sure. Okay. Anybody else want to talk about anything else? How about intermittent claudication? Can somebody tell me what it is, why I care, what we should do with it?
So you have pain when you're like exerting, right? But when you sit down, it gets better.
Uh-huh.
Doesn't it have to do with your valves failing?
No, because this one's in the arteries. This is
Oh.
for PAD, and the valves, there's no valves in the arteries.
Right. So it's not okay. So I don't know, because you're gonna get a DVT. I have no idea.
But again, that's a vein one, right? So
Oh,
the
yeah,
reason
it
that
is.
you get intermittent claudication is because your artery is so narrowed because of atherosclerosis that downstream you're walking, so your muscles requiring more oxygen, right? When you exercise, you need more oxygen. And so you're requiring more oxygen, and your body's like, hey, you're asking me to do this work, but you're not paying me anymore. And that's what the pain is. So they get better, like Melissa said, when they sit down and rest, because now they don't need as much oxygen, right? But again, they're going to get back up and walk that same amount again and have that same issue again. Okay. So that was good, Melissa. Practically there. And just, all I needed you to make sure is that it's good for arterial disease diagnosis. Rest when it hurts, but then get up and make them walk more. Push them. Because the idea is the more exercise you do, the less atherosclerosis you do, the less intermittent claudication you get, the less chance you have of having PAD. Okay, how about rubor? Tell me what rubor is. Is it good or bad? How do I get it?
That is good, right?
It is
Because
good.
you're hanging their legs. And
it's
then
arterial as well, right?
Yes, perfect. Together you made it exactly right, guys. Good
perfect. Can we take the test together?
job. Right? No. But together, Melissa and Carla made the right answer. But yeah, you guys got that. Rubor is good for people with PAD. When they dangle their feet, it makes them feel better. Even though you and I, without PAD, when we dangle our feet long enough, it would hurt.
So when they elevate them, they get pallor.
Mm-hmm.
And that's when there's like no blood flow in there. They get really pale.
Right, because they're not only working against atherosclerosis being so narrow, but now they're working against gravity. And so it's just like holding your arm up for too long, right? It's going to get nice and pale because you're not having enough blood flow to it. Okay, how about venous insufficiency? We start with swelling. Anybody remember what the next step of venous insufficiency is? It's this purpley bruise on your medial malleolus. Do you remember what it's called? Venous stasis. Okay. And then, I'm sorry, I take that back. Stasis dermatitis. And then if it sits there long enough, the blood is just eating through the vessel from the inside out because the blood's just sitting there. Blood's not supposed to be sitting there, right? But their veins and their valves are so crappy that it's sitting there. And then they end up getting a venous stasis ulcer, which is that big, it looks like a pressure sore, but it's a sore from the inside out. The blood is just eating through the skin on the medial malleoli. And then those usually get infected, causing cellulitis. So it starts as swelling, then then stasis dermatitis with the purple bruising, then venous stasis ulcers, and then cellulitis. Okay, so tell me about venous insufficiency. What's our first stage? This is just what we talked about. I'm just having you reiterate it. Yep, swelling.
So inflammation, swelling.
Then stasis dermatitis.
Then stasis dermatitis, perfect.
And then venous stasis ulcer.
Great.
And then the cellulitis.
And then the cellulitis gets infected. Good job, guys. Very good. Okay, What about, what are you going to tell a patient whose family member just had a stroke? And on the NIHSS, the stroke is a 3. What are you going to tell that family member?
0, I believe, is not that bad, and 45 is really bad.
42 is the worst.
42, dyslexia, don't know my numbers.
No worries.
42. So I'm guessing I would say that they had a stroke, but it wasn't severe.
Good, good. So now let's say you have a patient and on the NIHSS, the stroke is 40. What are you going to tell that patient's family?
We would tell them that it is severe, and it may, in that one, you cannot recover from generally, correct?
Correct. You're going to have to teach the family to take care of the patient. You're going to have to teach them maybe they'll need to go to a rehab or a skilled nursing facility. You're going to teach them that this patient can't live at home alone anymore. They've got to start modifying the home environment so that they either live with someone or they're on a ground floor or they have someone come in or they go live somewhere else, right? So that was good. You guys touched on kind of the hope versus reality conundrum, right? When it's really bad, you need to make sure the patient's family knows how bad it is. But when it's very, very mild, like a 3, right? You can be like, okay, well, they had a stroke. This is why, list the cardiovascular risk factors, right? And to prevent it in the future, they can stop smoking, lose weight, eat better, right? But they should be pretty back to normal after some rehab. Usually those patients go to rehab. Okay, can anyone tell me why when we're looking for a stroke, we do a non-contrast CT first thing? Why non-contrast? Do you remember?
Because if it's a hemorrhagic, it would leak into the tissues.
Right. And this is nuclear medicine, right? We don't want to put something radioactive on brain tissue. In fact, we barely want to put it in the blood vessels. So very good, Melissa, very good. Okay. Let's see. We talked about stroke, hypertension.
Can we talk more about the is it Berger's disease?
Absolutely.
Is that a venous insufficiency as well?
Arterial.
That's arterial. Okay.
That's arterial.
Yeah. Let's go over those because there was 2 of them, right?
Right. Raynaud's phenomenon and Berger's disease. It's like Raynaud's is down here and Berger's is a step more aggressive. They're very similar though. Raynaud's, you have intermittent arteriolar occlusion. Every once in a while, their arterioles shut, but then they open back up again. That's Raynaud's. Berger's, their vessels are so inflamed that they don't open back up again. They just stay inflamed, which means these people are getting days, months, years of no blood flow to their fingers and toes.
Okay, so those are both arterial. So
Both
for
arterial.
venous, do we need to know more about like varicose veins?
For varicose veins, you want to know prevention is really good, right? Wearing TED hose or wearing compression stockings. Don't sit for a long time and don't stand for a long time. 50 minutes to 10 minutes should be your interval. If you have to sit for 50 minutes an hour, stand for 10. If you have to stand for 50 minutes an hour, sit for 10. So varicose veins are mainly the prevention because varicose veins lead to venous insufficiency and all those problems we talk about, which could cause a DVT, which leads to a VTE, which leads to a PE. Okay. What else did we talk about?
Could you go over VFib also?
Absolutely. So VFib, ventricular fibrillation. This is when the heart has no coordinated contraction. Every muscle in the heart, and you know the heart is made of a bunch of different muscle cells, right? Every muscle cell in the heart is doing its own thing. And fibrillation has been described as a bag of worms. It's like if you saw the heart, it's supposed to be opening, shutting, but it's going like this. Every heart muscle is doing its own thing. So VFib on an EKG looks like nonsense, because every muscle is doing its own thing and it's not paying attention to the muscle next to it or the atria above it. It's just doing its own thing. So for VFib, you are never going to have a pulse. You are going to jump right into defibrillation. Now, the only pause you would do is if you started CPR and you scream for someone to bring in the cart and you're doing CPR. And as soon as they get the pads on the patient, you shock them as soon as possible. So VFib, DFib. Then you do 2 minutes of CPR. Check again. Are they still in VFib? Yes. Shock them again. Then do 2 minutes of CPR with epi, with 1 milligram of epi. And then you check at 2 minutes. Are they still pulseless? Are they still in VFib? Yes. Shock them again. 2 minutes of CPR. This time we can add an amnio. And you go in that cycle for, you can only do 2 doses of amnio total. So you could do epinephrine like 100 times if you needed to. And you will go until the patient has ROSC, which is ROSC, return of spontaneous circulation. So their pulse comes back. Because at those 2 minutes, you check to see, okay, oh, they have a pulse, where we're going to stop doing CPR now. Okay, so if they have a pulse, that's ROSC. Or if everybody in the room agrees, it's time to call time of death. Then we stop, right? But I've seen them do codes, usually on adults, 20 minutes to an hour. But on kids, they do it over 2 hours long. And some of these kids actually come back fine. Like kids are super duper resilient. It's amazing. But yeah, usually 20 minutes or so is where we go. We start off for all adults, and then depending on what the family wants and depending on what people feel in the room, it's a really unscientific way, but they're like, the doctor will say, is everyone okay that we call it? And that means, are we okay letting this patient die? If even one person in the room says, no, keep going, we keep going. And it doesn't matter who that person is in the room. It doesn't matter if it's the janitor or the doctor. Anybody says they're not ready to let this patient die, we will keep going. If the family wants us to keep going, we will keep going. But usually somebody will go and talk to the family and explain something to the effect that only 17% of people survive CPR. Did you know that was true? Only 17%, which seems like practically nobody. But in the scope of people to get CPR, 17% survive. That's something, right? It's better than nothing. So did that answer what you wanted, Alphon? Okay. Okay, we got about 20 more minutes. Just
back to the Buerger's disease. What would be the interventions?
Good question. It has a genetic component. So genetics, you can't really intervene, but keeping things down that are, don't smoke, right? Because that will decrease your ability of your vessels to inflame. And don't do anything that's going to cut off your circulation. Like don't wear tight clothes, avoid the cold, avoid stress, which really isn't avoiding stress, but dealing with stress, right? That could help a bit. But mostly these people with Buerger's are going to escalate to the point where they get amputations, and they might get like the tip of their finger amputated, and then 10 years later have this part of their finger amputated. Then 10 years after that, their whole finger's amputated. It's a progressive disease that doesn't go away. Good questions. Okay, I was going to say, we've only got Melissa, Carla, and Elf on here, so you guys can ask anything you want. So EKGs, we've got normal sinus rhythm, sinus tach, sinus Brady. Do you know how to differentiate between sinus Brady that's symptomatic and it's asymptomatic? Symptomatic sinus Brady, change in level of consciousness, hypotension, decreased urine output, just like the unstable versus the stable that we were talking about at the beginning. So symptomatic sinus Brady is when someone is getting real weird because their heart rate's so slow, right? They can't wake up maybe. They're saying things that are confused. They're not making any urine, stuff like that. That would be symptomatic sinus Brady, and that's where you need the atropine. Then we got sinus tach. Do you remember how to treat sinus tach? That one's kind of a unique one.
The cause.
Treat the cause. Good. So if they're tacky because they're panicking, try and calm them down with breathing exercises and give them a benzo. If they're tacky because they're febrile, give them some Tylenol. If they're tacky because they're in pain, give them some pain meds, right? Whatever the cause is. SVT. Melissa knows which drug is for SVT, Melissa.
Amiodarone. Wait, oh my heck, hold on. It's not atropine, it's the other one.
It is. It's the other one. It's not amio and it's not atropine.
Proketamine. What is it? It's the adenosine, sorry.
So remember, I think of adenosine. I don't know how many of you have seen my tutoring time, but I think of adenosine as adenosine. It's got to stop that SVT dead. It's like a full reset. You have to turn your computer off and turn it back on. That's what adenosine is. And we only use it for SVT. And the reason I picked on Melissa is because she asked me at the beginning of the which one it was for.
It's really good. I love questions. Thank you for asking questions. This is how I learn. So thank you.
Good. I'm glad. So SVT is adenosine. And then if that doesn't work or if they don't want it, you can do cardioversion. Because remember that one, if they've gotten it before and nobody told them, we're going to stop your heart and make you feel like you're dying, they're never going to get it again. And they're going to go into SVT again. People who go into SVT always go into SVT because they have that little bundle in their ventricles that gets the electricity confused. Okay, then we've got AFib and AFlutter. Can somebody tell me how you guys differentiate between AFib and AFlutter? How do we know which is which?
So I just remember the sawtooth pattern with AFlutter.
Perfect.
It just really helps me.
Good. Okay.
Their treatments are different. So
their treatments are very different, right?
Also with AFib, I just think of like it's going so fast. So with AFib, your heart rate's, what is it? 350 to 4. It's like insane.
Well, that would be your atrial heart rate, right? Because we don't.
That one, you think, I just am thinking like it's not really a good solid pump. So there's still blood kind of just sitting in there. So that's how I remember that we need to not let a clot form. That's how I remember we need to give them anticoagulant, and then the ablation possibly, because we need to get rid of the rogue cell that's making it go crazy.
Perfect. That's exactly right, Melissa. Very well put.
With AFlutter, I was thinking of like the drunk butterfly and the whatever. I know that you think that for that of something else, but I'm like, let's give it a beta blocker and a calcium channel blocker because we need to just calm down this drunk butterfly.
Love it. I love that. I might have to steal that from you, Melissa. I like the drunk butterfly idea. You got to calm down, right?
Yes.
What electricity do we use if either AFib or AFlutter are unstable?
Cardiovert. We don't defib anybody with a pulse, and AFib and AFlutter have a pulse, right? How about our 4 pulseless rhythms? Alphon brought up one earlier with the VFib. What are our other 3 pulseless rhythms? So asystole, VFib, PVT, and PEA.
PEA, but PVT isn't. Oh yeah, it is pulseless ventricular tachycardia.
I'm like, oh my gosh.
No, it is. You're right. Oh my gosh. I just don't, I write it as PVT, but I never say it as PVT. So that was my bad. You are right, Melissa. So those 4 are going to be your only pulseless rhythms. But remember, if you're looking at a strip and it says pulseless, it's probably going to be PEA, right? Because PEA can look like anything except VTAC, VFib, asystole. So if you see the word pulseless, that completely changes your plan of care. Okay, so watch out. Take those questions on the test nice and slow and watch for the word pulseless. Okay, we talked about heart blocks. Anybody want to talk about heart blocks again?
Maybe just a quick recap.
Okay, so the quick recap, I like the poem, right? So if the R is far from P, then you have a first degree. R from P is your PR interval. So a first degree has a PR interval above 0.2 seconds, which is bigger than one big box. And remember, the PR interval goes from the beginning of P to wherever the isometric line deviates to get to your QRS complex. Okay. Second degree type 1, longer drop, then you have a second degree type 1 block, right? So what's happening is your PR interval is normal, and then the next one is a little longer, and the next one's a little longer, and then the next one you have a P, but no QRS complex. That's our drop. We drop the QRS. Remember, the QRS is when the ventricles contract. So the PR interval is getting bigger, giving us warning, hey, I'm about to drop a beat, right? So second degree type 1, you get warning, and it goes in a pattern. This length of PR interval, then this length, then this length, then we drop, then start all over, and then we drop it, okay? So second degree type 1 is in a pattern. Second degree type 2 is more dangerous because it's unpredictable. We don't get the warning. It doesn't go PR, longer, drop. It doesn't do that. It does normal. I'm normal. I drop. Wait, you just drop? There was no warning. Second degree type 2 is kind of like bipolar person. Without warning, they completely lose it, right? So second degree type 2 is very dangerous because it's unpredictable. The PR interval is either fine or it's absent. And then let's see, what's the word for that? I'm trying to think of the poem for second degree type 2. If some P's don't get through, then you have a second degree type 2. It says Mobitz too, but it's second degree type 2. That's just an old name for it. And then the third degree, if P's and Q's don't agree, then you have a third degree. So you'll look at all the PR intervals and they march out evenly. If there's this much space between this P and this P, there's going to be that much space between the next 2 P's and the next 2 P's and the next 2 P's. Because the SA node is fine, the P waves are fine. What's totally shot to hell is your AV node, completely dead. So the electricity doesn't make it from the SA node to the ventricle, because the AV node is supposed to push it through and it doesn't. So the P wave is fine because the SA node is fine, but the QRS has to pace themselves, and they are very slow when they pace themselves. So you'll have P wave, QRS wave, P wave, QRS, and sometimes all 4 chambers of the heart will contract at once. That's clearly not good for cardiac output, right? And then this, and then it comes in there, and they literally have nothing to do with themselves, right? It's like Dr. K was saying, he lives in this part of Canada, his wife lives on the completely other part of Canada, which isn't true. He was just giving us an example. When the P's and the QRSs are kind of divorced, they don't really talk to each other anymore. Okay. Second or first degree heart block, how do we treat it?
You don't do anything for a first degree heart block.
Correct. Second degree type 1, how do we treat that one?
It's the Holter monitor, and we're going to change their cardiac meds. Sorry, if anybody else wants to answer these.
I think they're okay with you answering, Melissa. Okay, second degree type 2.
So this is the pacer, and we're going to add a boy. We're going to give him some
Right.
atropine because this is bradycardic.
Perfect. Atropine and pacer. And how about third degree? How are we going to treat that one?
So same thing, pacer and
Yes.
atropine.
Perfect. How you feeling about heart blocks? So. Okay. Let's see. Then we talk about VTAC and pulseless VTAC. By looking at a strip, how can you tell if it's VTAC or pulseless VTAC?
I don't think you can, right?
Exactly. You can't. You have to physically touch the patient, or you have to read in the paragraph where I explain what the patient is doing, right? So if there is a pulse, there's VTAC with a pulse. What is my first go-to maneuver?
Vagal.
Vagal. If that doesn't work,
Cardio.
what's my, cardioversion. And if that doesn't work, or if the patient doesn't want cardioversion, what's my drug?
And the procaine. Procainamide.
Amiodarone and procainamide. And either one. Some doctors prefer amio because it's older, but now they're kind of moving more into procainamide. So either one would work. How about if I've got a VTAC without a pulse?
CPR.
CPR, and what's my drug that I can give? Epi. Good. Okay. How about VFib? What does VFib look like? Carla got it. Yes. It just looks like you let your kid color a straight line with a crayon or something. It's just nonsense, right? What are we going to do to treat VFib?
So you'll defibrillate and then start CPR for 2 minutes, defibrillate, push epi, that whole deal.
Perfect. That whole cycle. Yes, exactly. Okay. How about CPR? What's the first step in CPR?
You'll tap them and say, hey, are you okay?
Hey, are you okay? Okay. What if they're unresponsive? What's our next step?
Check a pulse.
No.
No.
Because if they're unresponsive, I don't care why they're unresponsive. You got to say, hey, Bree, call 911. I'm just saying Bree because she's behind Carla. Yeah, you got to get somebody. So the second thing you do, hey, are you okay? You in the blue shirt, call 911, then pulse. Because even if they have a pulse, if they're unconscious, you're still going to need help, right? What if they're unconscious because of CO2 poisoning? What if they're unconscious because of hypoglycemia or hyperglycemia, right? So you're going to need help. So make sure you call before you check the pulse. But then you check the pulse. What's after a pulse check? There's no pulse. There's no breathing. What do you do next?
You're going to start chest compressions.
Good. And what's my ratio of compressions to breaths?
So 30 compressions, 2 breaths.
Right. In the hospital, we don't really do that because we have a person that can breathe and we have a person that can do chest compressions. And frankly, every time you do a chest compression, you get them a little breath inside. Plus, their blood already had a lot of oxygen reserve. Do you know that deoxygenated blood still has about 80% oxygen? We just call it deoxygenated because arterial blood has 100% oxygen, right? So even though we're not breathing for them exactly how we're supposed to, they're still getting some air, some oxygen. So, okay, so that's for CPR. Let's see what else was on there. Feel free to ask me any more questions if you can think of anything. I'm just trying to go through the slides in my head right now. Okay, so tell me what rhythms would we use atropine for? Give me 2 rhythms.
Sorry, what did you say?
2 rhythms we'd use atropine for. Remember, attaboy. What are we going to use it for?
So sinus Brady.
Symptomatic sinus Brady, yes.
3rd degree.
3rd degree heart block, perfect.
2nd degree.
2nd degree type 2 heart block.
2, yeah.
Yeah, good. Okay. How about adenosine? Adenosine. What am I going to use adenosine for?
VTAC.
SVT.
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 I was too confused. Oh my God.
I know. Okay, you got to think of them in your head, right? VTAC has very wide QRS complexes. SVT has very narrow QRS complexes.
So what is your heart doing in each of these? Maybe that'll help me.
So with SVT, supraventricular tachycardia, the electricity is looping around in the SA node. It's just going around, or in the atria. It's just going around, 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 around. Okay. In ventricular tachycardia, the electricity is going around and around and around in the ventricles. I don't know if that helps or just makes it worse.
Yeah. Nope, it does.
Okay, good.
What helped me was just the name because it's supraventricular. So I compared those two and I was like, oh, well, the supra just makes it seem like that one would be the one that needs to just stop. So
okay, so it's like
helps.
supercharged. You got to stop it. Okay, I see that. I see that. How about amiodarone? Give me 2 rhythms you would use amiodarone for.
VTAC.
Perfect. VTAC. What else? You could give it for AFib. Remember, AFib is anticoagulants, antiarrhythmics. Amiodarone is an antiarrhythmic, so you could use it for AFib. Okay. What are you going to do in a patient with PEA? How are you going to treat PEA?
CPR.
CPR, and which drug do we throw in?
Epi.
Good. Yeah, you guys seem like you've got the rhythms down. You're answering those questions really well. We got 5 more minutes. Anything else you want to talk about?
Do you have the answers to, there was like a sinus, or not, I can't even think what it's called. There was like a worksheet, a practice worksheet in The module.
Module 5. It should be right there with it.
So
Let me
the
just double check.
EKG one's in there, but I don't see the I don't see it for the strip reading worksheet. I don't see the
answers aren't in there. Let me just double check. Let's see.
I just see the EKG answers.
Strip reading worksheet. Oh, that one. I think oh no, I don't have that for that, but we can go through it if you want. We can talk through it.
Okay, that'd be awesome.
Oh, it's because it's all the okay, yeah. Okay, so let me share this with you. You're talking about this one, right? Oh, whoops, wrong thing. Sorry. Wrong thing. This is the one you're talking about, right, Melissa? Is this the one you're talking about?
Oh my heck, sorry, I couldn't get my mute off. Yes.
Okay, so heart rate range for this one. So this would be 300, 150, 75, and a little below 75. Or you could do 1, 2, 3, 4, 5, 6, 7, 8, 9. How many seconds is that? 3, 4, 5, 1 second, 1, 2, 3, 4, 5, 2 seconds, 1, 2, 3. 3 seconds, 1, 2, 3, 4, 5, 4 seconds, 1, 2, 3, 4, 5, 5 seconds, 1, 2, 3, 4, 5, 6 seconds. We get 1, 2, 3, 4, 5, 6, 7, 8. 75 to 80 for that one. Okay.
So if you scroll down, I think there's questions at the bottom. That was
That's
more.
what you want more.
I just want to make sure I was doing them correctly.
Okay. The pacemaker of the heart is located in the SA node. That's that primary pacemaker of the heart. A telenurse assesses a client with a 3rd degree heart block. At 35, which assessment should the nurse complete next? Breath sounds, pulse strength and amplitude, level of consciousness, cap refill. I would say airway first because your airway breathing circulation first. So I would go with A on that one. Okay, what dietary restrictions does a client have while on calcium channel blockers?
Grapefruit juice.
Perfect, no grapefruit juice. Okay, what's this rhythm here?
That is VFib.
VFib, good. Okay, this is just talking about small and big, large boxes. So do you want to like these questions right here, or did we answer what you got?
No, it was mostly just those. I thought there was more. I'm just, oh my heck. I clearly like feel better because I feel like I knew a lot of the answers today, but there's just so much. And
no worries.
And I also feel like I was looking up ECG practice like quizzes and stuff, and their strips look different than these strips. So so on the exam, are these like mostly the strips you're going to be using, or?
I'm going to use a strip that is clearly the rhythm you need to look for.
Okay.
They won't be this exact same one necessarily, but they will be very clear as to which rhythm they are.
Okay.
Yeah, because sometimes you're like, oh, is this that or is it that? Yeah, this will be very clear as to what it is. Okay.
Barf. I do not want to do this.
Well, you have to, because now you have to practice because you still got to get in time to do your reading and you're watching your videos for the flipped classroom.
Oh, and we have a PEDS exam that I haven't even looked at. So
just throw some more on there. Yeah, might as well, right?
Yeah.
Okay. Well, that's an hour. Anybody else have any questions? Anything else you want to talk about? Okay.
I'm sure I'll think about it later.
Feel free to email me if you come up with something later. Okay.
Thank you so much.
Good to see you all. You're so welcome. Have a nice rest of your day. See ya.